Thank you. And I would like to share the screen from my end. And in continuity to what Dr. Sudhir presented, docetaxel, and darolutamide in a given situation. So I will be talking a little about this
Sir, sorry
molecule.
to interrupt. Just make it full screen, sir.
Yeah, yes. Is it full screen now? So I will
Yes,
be
sir.
talking about this molecule in a given situation that is a non-metastatic prostate cancer. As we understand that majority of the patients, they have the localized disease. May not be true in the Indian scenario, but yes, it is there. And these patients ultimately become the metastatic disease. They ultimately become from the hormone sensitive to the castration resistant disease and so on. Once there's a castration resistant metastatic disease, the downhill course becomes faster and the survival doesn't remain so good, and that depends on so many factors, including the volume of the disease, the visceral involvement, androgen PSA doubling time, and so on, and the other factors. So HSPC leading to the CRPC while the patient is on the this particular androgen deprivation therapy is something very interesting to us, and we need to most of the time understand it, that how it is becoming the resistant. So the patient with the non-metastatic CRPC can have the rising PSA level, but when they remain asymptomatic from their cancer, we usually call it as the non-metastatic CRPC. That means PSA is there, it's a rising, and radiologically, clinically, patient remains asymptomatic. So that's the situation, and that remains for a long period of the time, finally leading to the metastatic disease and ultimately becoming the symptomatic, castration resistant, and so on. And finally, the patient, most of the time, they succumb to their illness or the complication. So these metastases are associated with a decreased survival and quality of life and the increased healthcare cost. So it remains a concern not only for the patient or the caregiver, but as well as for the healthcare provider also. So the key therapeutic goals in nmCRPC are to prolong the survival without disrupting the patient's daily living or the quality of their life. So there are the three things, that is the extending the survival or the overall survival of the patient, quality of the life parameters, as well as the PSA related anxiety, both in the mind of the physician as well as in the mind of the patient also. So the M1 disease on the PSMA PET, there's a new thing which is coming and bothering us, that how to deal these patients who are probably the negative on the conventional imaging versus PSMA PET becoming the positive. The volume of the disease remains so the more and more the thought process are that these patients should not be deprived of the non-metastatic prostate cancer scenario. So the present guidelines in the systemic therapy for the M0 CRPC is that you do the imaging, continue the androgen deprivation therapy to maintain the castrate serum level of the testosterone that is considered as the less than 50 nanogram per deciliter. And depending on the PSA doubling time, more than 10 months versus less than 10 months, you try to choose or dissect your patients accordingly. So patients who are the slow progression, like more than 10 months, PSA doubling time, you can monitor them, or you can consider other secondary hormone therapy versus patient less than 6 months. So the present preferred regimes are the apalutamide, darolutamide, enzalutamide. Apalutamide we will not be discussing here because presently this drug is not available with us directly in India, and there can be the other recommended regimes like the other secondary hormone therapy also. So I will be basically talking about the Aramis trial design, which is a global randomized phase 3 trial investigating the safety and efficacy of the darolutamide in non-metastatic CRPC. The trial design remains the simple. The patients are with the PSA doubling time less than 10 months. Stratification was done less than 6 months versus more than 6 months but less than 10 months, and use of the osteoclastic target therapy. And these patients randomized 2:1, that is the ADT plus Daro 600 BD versus ADT with placebo. The primary endpoint of these trials, all these similar trials, remain the metastasis-free survival, and lot of other secondary endpoints and the exploratory analysis point remains there. So coming to the darolutamide, which is a non-steroidal androgen receptor antagonist with the high binding affinity and selectivity for the receptor. So that's a very important, and there's a little bit differentiating this agent from the other two drugs, that is the apalutamide and the enzalutamide. The other thing is that it has probably the low blood-brain barrier penetration compared to the other competing molecules from the similar class, that is the enza and the apalutamide. And here we can show that it has a remarkably low CNS penetration or through the blood-brain barrier. So this makes this drug that it doesn't have the much impact on the cerebral blood flow, and probably the making it more safer, because we also understand that we don't want much activity of these drugs in the CNS, because CNS is probably not the first or second time the metastatic site for the prostate cancer. It may happen once in a while also. So we have the three trials, three molecules, that is the Spartan, Prosper, and the Aramis, based on the darolutamide, apalutamide, and the enzalutamide. The primary endpoint of these all trials, which are having almost similar designs as far as the primary endpoint is concerned, and we have the three molecules from the same class. So the overview of these three trials, phase 3 trial, is here. Large number of the patients are there. Primary endpoint remains the same. Additional endpoints also remain more and more similar, and the eligibility criteria also remains more and less similar out of these three trials. But if we look at the primary analysis, the metastasis-free survival contrast to the placebo is the 40 months versus again the 40 months versus less with the enzalutamide. And as far as the final analysis of the data is concerned, if you look at the hazard ratio, it is a 0.69, probably the most in favor of the darolutamide compared to the EPA or the enzalutamide. That is the 31% chance of the risk of the reduction in this particular molecule. So subsequent life-prolonging therapies in patients who discontinue study treatment. That's the new point, because we know that a lot of drugs are now available, like not only the molecules of the androgen receptors inhibitors, we have the abiraterone acetate also, and we have the chemotherapy also, and that also the subsequent line of the chemotherapy also. And in this particular scenario, non-metastatic castration-resistant patient who remain virtually asymptomatic, Sipuleucel T may be the another choice for the select group of the patient. So the secondary endpoints in the Aramis, Spartan, and Prosper also are very, very important to understand, and probably to select the drugs in the given scenario. So the summary of the treatment emergent adverse events, if we look at contrast to the placebo, all of them three are doing better. But if we look at the cross-trial comparison, which may not be the right way, but yes, here we can see that in the Aramis trial, the darolutamide contrast to the placebo or across the various other molecules, it looks numerically better in favor of the Aramis trial or darolutamide molecule. So the permanent discontinuation due to the adverse event is a measure of the treatment tolerability. So that's the new way to analyze the treatment tolerability. And here again, if we look contrast to the placebo, we see DARA versus placebo remains the same. Contrast to the EPA, where there's a huge difference, contrast to the placebo. And similarly, in the enzalutamide trial also, there is a Prosper. Contrast to the placebo, there is a huge difference of the permanent discontinuation. So what I would like to conclude as far as the efficacy, safety, and the quality of life parameters are concerned, the darolutamide significantly reduced the risk of the death by 31% in the patient with a non-metastatic CRPC, that is the hazard ratio 0.69. It significantly improved the clinically meaningful endpoints, including delayed the pain progression by 15 months and reducing the risk of the initiation of the cytotoxic chemotherapy. And DARA demonstrated a median metastasis-free survival of the 40 months. That is more than double the median MFS with the placebo, seen with the placebo. And this was observed regardless of the PSA doubling time at the baseline, whether it was less than 6 months or between 6 to 10 months. So safety, again, probably it is in favor of this particular molecule than the enza or the apalutamide, but that is just across the cross-trial comparison may always not be the right way. And because it is being the non-metastatic disease, so the quality of life parameters are of the great concern with this particular molecule. So with this, I would like to thanks once again from my side for joining this important webinar. Happy festive season. Thank you.
Thank you very much, Dr. Naresh, for bringing this update on darolutamide. I think you made that point very clear, that these patients are having no symptoms whatsoever. So whatever intervention we do should not in any case jeopardize their quality of life. And that is I think the best thing about darolutamide, that the discontinuation rates and the toxicity is sort of minimal, and therefore patients are able to take the drug for a longer period of time, because I mean, there should be no cognitive dysfunctions or CNS toxicity, or some of these drugs that are related with hyperlipidemias and so on. So I think the most important issue with such interventions is, I mean, of course, they have to be effective, which has been shown, but I think the safety is of paramount concern, and which I think darolutamide has shown in this particular trial. So I think if there is no more question on this, I think the only issue to my mind is most of these patients are going to be treated either by urologists or with the radiation people, because these are patients who have been offered curative treatment, either radical surgery or radiation. So they are in close follow-up with those physicians. So we generally come into play when there is, a metastatic disease. So I think that is an issue which we will face in our day-to-day practice. So any comments, Naresh?
Yeah, I do agree, sir. And rather, I realized now that rather than focusing more on the medical oncology for this particular aspect, we all should have the joint efforts to make the urologist sensitize that how the non-metastatic disease should be tackled.
Right. So I think this becomes a multidisciplinary care where the patients are going to be with the radiation oncologists or the surgeons mainly. So they also need to be engaged in the discussions to institute this particular agent when there is no metastasis and patient has rising, PSA, and the patient is on ADT with the control in the testosterone levels. So I think with this, we move on to the last session in or lecture in this session,